We can see you and we can hear you. Can you hear us?
Yeah, Alex, Ajay, Kirtane and all the excellent panels there. We are actually doing a live case from National Cardiac Center, Indira Gandhi Memorial Hospital, Male. You know, Male is known for its tourism and fishing and one of the tourist destinations for anybody in the world. We have an excellent panel of doctors here. Me, Dr. Prathap Kumar. He is Dr. Ali Shafiq, he is the director of National Cardiac Center. Dr. Mikdad, head of the Department of Cardiology here. Then Mausood, he is the consultant cardiologist in Male. And Shanis, he is the director of HOD cardiology now. We have technician Manjula, then cath lab nurse Asha. We will be going directly to the case, an interesting case. Actually, a lot of discussion is required. Can I have the presentation by Mausood? Can you show the case? Can you go? Can you go?
Can you hear me?
Yep.
Can you hear?
We hear you and we can
Okay.
see the slides. Go ahead.
Okay. Welcome to today's presentation from Maldives. So today we have a 60-year-old lady without any prior comorbidities who presented to us with exertional dyspnea, functional class 2. She was evaluated with ECG initially, which was normal, and
Next.
echo was showing normal LV function without any wall motion abnormalities. She also underwent a treadmill test, which was strongly positive at stage 2, and she also had syncope during stage 2. So she was taken up for angiogram, which was showing LMC, a trifurcation disease involving distal left main and ostial RI. RCA was normal. So I will hand over the case to Dr. Prathap, and we calculated the syntax score, which was also
Next slide.
18.
Okay. Actually, with this, we have a syntax score of 18 and an interesting angiogram with the ramus is tightly diseased. A lady, I will tell by angiographically borderline disease, and distal LMCA is involved. So today, can you go to the first
And
angiogram
Pratap,
today?
there was no valvular disease or RV dysfunction on the echo?
Nothing.
Because the
Everything is
syncope is
normal,
pretty
Ajay.
unusual.
Everything is normal, Ajay, because the patient had a syncope during the treadmill towards the end of the treadmill test and strongly positive. Recovery took nearly 14 minutes for ECG becoming normal. And so this was the angiogram taken today. Today's angiogram? Today's angiogram. Can you just freeze the angiogram and next shot? Can you, Ajay, you want to discuss? You can discuss, and this is the angiogram today.
I think that imaging would be very important in this procedure, in this case. I have a little bit of an issue here with the distal left main. It's not absolutely clear to me if there is a lot of disease there. So, Kiko, when you recommend IVUS or OCT in this case, would you do the pullback in the 3 vessels?
I'm sorry, yes.
I think
You will have a pullback of IVUS?
Dr. Prathap,
Yeah.
this is Dr. Gambhir.
Well, tell me, sir, please.
I do agree with other persons on the dais that it's not a very critical distal left main. Of all the 3 vessels which are rising from the distal left main, I find the obtuse marginal one has possibly the tightest stenosis. Others are maybe moderate disease, so I think one would need further evaluation by IVUS, OCT, and find out how much is the plaque burden, whether one needs to really do an intervention in a situation like this.
So imaging is a must in this case, and we actually decided to do imaging by both IVUS and OCT. So to understand that what is the plaque morphology,
I
what
think
is the lesion length
No,
and everything.
I
I will
think
go to
this-
the first IVUS.
Yeah, go ahead and show the images. Just 2 things.
Yeah, can you-
just technically, though, because of the angulation into this, ramus high OM as well as the circumflex, you have to be prepared to deal with this, what Kiko will call wrinkling artifact or some sort of artifact there. And the second thing, I mean, if the left main doesn't look that significant, with that story you mentioned, other diagnoses like profound microvascular dysfunction or other things can also explain. Because to me, stage 2 syncope with that lesion does not seem to make clinical sense. So let's see what you got.
So that's a
Can you
left
go to
main
the-
already. Left main, distal left main looks like we are already outside of the, this is the proximal portion of the left main.
Can you show the initial, starting from the, it's a circumflex. We actually put 3 wires into the circ, ramus and all. It was not very critical for me. It is easily, I could wire. Can you show this is circumflex? Can you just go?
Okay, so.
Akiko, can you explain?
Sure.
Okay.
This is, stop, don't move.
Yeah, sir.
Just stop
Wait.
there.
Can you go back?
Can you go back again?
Go back, stop.
Okay,
Okay, so starting here, everybody, it's very clean artery. The vessel diameter is like 3.5, start.
Correct.
Actually 4. It's a little bit
Okay.
over. It's okay. Yeah, just play. Just play.
Just
Can you
play.
You play from the initial
Yeah,
distally.
that's
That is-
already trifurcation. That's like wrinkling we just passed. This is a proximal circ.
that is actually came to LMC already.
Yeah. So even the automatic pullback, it's very difficult where exactly the distal left main. So we have to look for one by one.
Can you just go back again, Shanice?
Yeah.
You start and you just leave it. Let her explain.
Okay,
Okay,
so
we will
this is
just
actually, yeah. Okay, this is a circumflex, and we are looking the very stenotic segment. That's like the OM and trifurcation. Actually, okay, so this is already left main. So I think probably better to start from the left main and bringing a little by little. So can you stop? And then bringing a little by little. So this is a distal left main, a little bit more distally. Thank you. More distally. This is a distal left main. Looks like critical. And then we already passed. This is already jump. This is a, yeah, we already circumflex.
But
Ramus, can you just go a little more proximal?
it's tough though because it looks
Yeah.
like it jumped,
Yes.
and also there's
Yeah,
the
jump,
bend,
jump.
and there's the bend.
Go back with the catheter and stop there for us to.
So this
perhaps
is a
better
distal
evaluate.
left main. Go back a little bit distally, please. That's the distal left main. We already jumped. That's already circumflex. So 1 or 2 frame proximally, that's actually kind of like the bifurcation. It's
Okay, actually, I will go to the Ramus now. Go to the Ramus. We will
that's a
show
good
everything because
example
you,
for the difficult
Yeah,
yeah,
that's a
diameter.
very
this is
good
Ramus.
Okay, Lima should be best because that's more straight. That's small artery, only 2.5, but quite normal. And we are pulling back. We should see the trifurcation. Looks a little bit spastic, very spastic.
Can you see some hematoma
Yeah,
there?
could be this is negative remodeling, quite interesting. This is looks like a hematoma, or what is this? Looks like a hematoma to me. Yeah, it's very big hematoma, which already damaged.
We did not do anything. Just
Yeah.
put a wire.
Okay, so this is okay. This is
Just
just
stop it.
distal to the. Okay, so we are. This is exactly distal left main here, which is very critical.
Very critical.
Yeah, I do
So,
think that should be hematoma. Go
A
distal.
hematoma, I don't know why, because actually we just put 3 wires, that's all. I did not dilate anything. And can it be a SCAD created by the, I don't know what has actually happened.
Okay, so
really?
I think actually this is a
hematoma.
very good, interesting picture. Starting here, can you play one more time?
Can you play again? Just Shanice can, okay. Then
Actually-
go back.
We already passed.
You just go to a little more, just start. Okay.
I do think this is a hematoma.
Stop there. No, just go back and then show the hematoma. No, only hematoma part.
Pratap,
Okay, just,
maybe this was a dissection caused by the wiring.
so this
I would give another angiographic look to see if there is any correlation, but this
no,
is certainly
same
hematoma.
as the earlier. I will show you that. Next I will go to the LED first, next. Because I wanted to show everything
Yeah,
and
show
then
the
come back.
LED. The LED would be fine.
Okay, LED.
So this is LED. Looks like the myocardial bridge. We are about 3O vessel. And coming back, you see
Can
the
you see,
bridge?
Kiko, the
There is a
LED
bridge
image?
on top, 12 o'clock, that's a myocardial bridge.
Sound is not heard.
Yeah, can we see the IVUS again? It went back to the angiogram.
Yeah, okay.
Perfect.
Okay, so we are much more, this is quite interesting. That's actually vein. Outside, it's not like the funny picture, but anyway, this is a disease. That's outside structure is vein. This is a disease, but not too bad in terms of the stenosis. And mainly the plaque is like the mixed plaque. It's not super calcified. And this is some calcium is not too bad. This is tight
Calcium.
region in the LAD, but calcium was not too bad. That's a trifurcation. We come back.
LMCA tight.
Yes, that's actually the LAD pullback is the most useful. We see the nice distal left one was super tight. But I think the plaque was not too bad in terms of the calcification.
So there is disease at the distal left main.
That's very tight,
Yeah,
yes.
it's clear now.
Yeah.
Very tight LMCA distal disease. There is a proximal LAD that's tight disease, third proximal disease, and ramus has a hematoma in the proximal part, which is like 2.25 millimeter vessel. So I had done one OCT only to the LAD. Can you show the OCT now? After that, we will discuss about what to be done. This is OCT run.
So this
Sarath,
is
can
nice
we-
chat artifact. It's when we do the like very torture surgery, we see this type of chat artifact. Now it's good. That's myocardial bridge. I think this is LAD pullback. And this is okay
Yeah.
place. Some like the lipidic calcified plaque, but lumen was okay. We are coming back. That's very nice lipidic plaque, some calcium. But in general, it's mixed plaque. And coming
Correct.
back, it's a lot of chat. That's a trifurcation. We come back a
Very
little bit
good.
more. We see the distal left main. Yeah, almost like passing. That's
Very
all.
tight,
Yeah. Yeah, tight.
very tight LMCA.
Yeah, here is the tightest we just passed, and this is already proximal. It's very far.
What is the area there? 2.25. In that some segment is only 2.25.
Yeah,
And LMCA
what's-
distal part is.
I'll say what's nice about it is it's very tight, so that, you know, if you were concerned with the bending and the artifact induced by that, that it would be somewhat off. If it were borderline, you might be a little bit less inclined, but with this, I think it's important. Just one thing, because not everybody has access to both OCT and IVUS, and as you could notice, this one, the pullback goes from left to right. The IVUS, it goes from right to left. All systems at the bottom right, you'll see a P and a D on the bottom left. That shows proximal distal. That's one way you can not get confused about what's proximal and what's distal. All the systems have that. So, okay, so what's your plan, Prathap?
My plan is actually to do the ramus intermedius, a cutting balloon, and then a pullback to ramus intermedius. And since both circumflex and LAD is tight, we can either go for a decay crush or a mini crush technique to the LM to LAD and circ. And ramus just can keep a cutting balloon followed by a drug-coating balloon. That is my plan. Is it a okay plan?
The one question I have for you, though, is that with this unexpected finding of a hematoma in the ramus, would that change your strategy? And maybe then if you show the angiogram again,
I'll show.
could you potentially do the
Now,
two-stent strategy?
now can you
into
come
the
back
ramus
again to
study?
the angiogram? Just make it a bigger image, and can you just double back and show that part, middle part? Let's little go.
With
No,
the
little
dye.
the apex. We have to show the apex. Okay. Similar picture, Ajay.
Yeah.
So I think my point of discussion before seeing this angiogram itself, to do a drug-coating balloon into the ramus and an angioplasty, if at all significant, proximal circum, proximal LAD coming, a decay crush or a mini crush to the LM bifurcation. That was my plan initially. Any panelist have a different opinion, I can do accordingly.
No, I
Dr.
mean,
Pratap, if there is a suspicion of a hematoma in the ramus, how safe is it to put a cutting balloon? Would you make a comment on that?
well, I mean, if
So
you release the hematoma, then it might work. The only problem is that if there is true compression of the hematoma, and if you look at the angiogram, it's a long segment of
it's a
compression.
long segment
the
of disease,
DCB
yeah.
is not going to do anything because
Yeah.
you have
Can
to
you
take it
just
out.
freeze the image? Stop. Okay, image.
So would you like to
Stop.
change your strategy for the ramus rather than doing a DCB? If you choose something else like a balloon and
Sir,
then put
actually,
in a stent,
my point,
It's
my
a very
point
big
is,
ramus.
So my point is I can do a cutting balloon to the ramus and I can do one more IVUS run to the ramus and see what cutting balloon did for the hematoma. Then we can take the strategy, because I don't want to put 3-stent strategy in a trifurcation, because I just wanted to have a minimum stent.
Right.
So in that level, I don't want to have a 3-stent and create a high restenosis for this patient.
So go ahead and why don't you go ahead and work and let's see. It's actually a very interesting thing, and we'll see it in real time what happens, because
Cutting balloon.
many people
Cutting
advocate
balloon.
the use of cutting balloons to
Am
release
2.25.
hematoma.
Just pay attention
putting
that
Higa
besides
extend
this severe lesion proximal, there is another dissection at the mid-distal portion. So I guess that you're going to have to deploy a very long stent. And I'm not sure if you could avoid going with the stent up to the osteo, perhaps not caging the other two vessels. Maybe you can try that. But certainly what I would react immediately is to deploy a very long stent in this ramus.
So, Alex, what do you want? Actually, putting a stent into the ramus or a cutting balloon and a
No,
balloon?
I
What
would
is-
go ahead with a stent, Pratap. I don't think there is any point of cutting balloon at this point. Perhaps a pre-dilatation would be okay, but I wouldn't take too much long because this vessel is going to close.
So this was during the IVUS run. So can you show it? Did you do anything else, or you just did the imaging and the patient's stable?
No, only imaging and kept for your discussion and then do anything. I did not do anything. Actually, now everything will be live.
Healthy
Okay.
run.
So this
This is actually cutting balloon 2 point,
okay. Let's
Yes.
see. Let's
2
see.
point.
This is cool.
2.510 I am taking a cutting balloon. Let us see what is inflate.
Yeah.
I just did 6 atmosphere and then keeping for 15 seconds to create the impact. Can you just show the timing?
So maybe a
I will do
question
an IVUS.
for Akiko. After the cutting balloon, should he just do IVUS or should he take a picture first?
Right.
IVUS,
Yeah, so-
because we should have
Yeah,
the
take a-
big,
My extend.
already making the big dissection, doing the contrast is getting worse.
Yeah, so
But
that-
fortunately, if cutting but making
cutting back.
re-entry, we may see the good flow.
That's another very good point. I think that Dr. Pratap wants to illustrate and document this case beautifully with IVUS and OCT. But when you see a hematoma by IVUS, I wouldn't insist in injecting more contrast as we do to
IVUS.
collect data on OCT. So IVUS data would be enough for me to make my decision.
IVUS. We will actually, Alex, all the CTO cases also, antegrade induction of contrast, I don't do at all. So in this case, particularly, we decided to do 2 imaging modality to make them understand that even I was confused whether LMC or distal is diseased or not. The proximal LAD was diseased or not. What was the strategy for this case? Very interesting case. Otherwise, to leave this patient with medical management without doing anything. These are all my questions come to my mind.
Yeah, I mean, super
Because-
interesting. But you have to definitely resist the urge. I think most people would say, let me try the cutting balloon. If the cutting balloon released the hematoma, then let's take a picture and see. And that's exactly the wrong thing to do, because you can extend
No,
the
nothing
dissection
to be
more
changed.
distal.
No changing. Why do you change the image?
And so, Prathap, this is a
Yeah.
seven French guide femoral. Is that what you're
7
using?
French guy with 3 wires. All the wires are filled with FC, which is actually probably my workhorse wire. That is not the good wire, but I always use workhorse wire as filled FC. I take OCT. Can you go to the IVUS now?
And let's see the
IVUS.
Oh, it's extended.
Some more, I can go
okay.
distally.
Still we have the big hematoma.
Okay, but so if you go forward, like you did, you'll see there's an area of normal segment where
Without
there's no
hematoma.
hematoma, and that's important to mark, so that way you don't have
Yeah.
to
Okay, so
inject.
this is a distal,
This
no
floral?
hematoma,
Yeah.
and looks okay. Normal artery, nothing. It's a
Mm-hmm.
big 2.5. Come back, no hematoma, and quite normal artery. It's okay.
So cine
Yeah.
here, you
Yeah.
would cine here.
Stop.
To see the landing zone for your stent.
So you see the black segment? That's actually staining the contrast.
Stent.
And you see the nice back and forth? That's meaning the entry site was closed. You
The
see
cut.
the nice entry
Yeah.
site? We just passed the 9 o'clock. This is even more proximal.
Wow.
Yeah, it's compressing the vessel, so I think have to make a decision quickly.
The decision is made.
You see the nice dissection entry side we just passed. So there is a connection in the proximal.
Yeah.
Still big dissection,
That's-
6 o'clock.
Yeah, so Dr. Leon talked about structural heart disease, but he had a slide when he talked about coronary disease that was a Nike sign that said, just stent it. And I think that applies in this case.
Length. Can you see that now
Yes, sir.
everybody's suggestion is to put a stent, right?
Yeah.
Immediately.
Immediately I'll put a stent and then I crush with a... I don't know, actually my wire would have created the hematoma or the hematoma was there earlier, which I don't know really what happened. But the wire is...
But Prathap, one thing that's important is if you looked at that IVUS, to me it looked like there was a segment where there was less hematoma, and that was not quite at the ostium of the trifurcation. So it may be, as Alex pointed out initially, that you can just put a stent in the ramus and not come back to the ostium,
Yes.
which would be an important thing to decide.
What is the length of the stent to be used? 2.25.
The 48 to start with.
28, 2.25. And we will keep 2 millimeters away from the ostium. What do you think, Ajay?
Yeah, I mean, if you go back to the IVUS, Kiko, you agree, right? It looked like
Can
the
you just go to
hematoma
IVUS?
ended and there was room at the ostium, right?
Yes. Yes.
Yeah.
And proximal portion
Can you
was
go to
already-
IVUS?
So come proximal, all the way proximal?
Come proximal. Show the proximal
Go
part.
fast.
It's already completely dissected. This is okay, no plaque, so you can landing here.
There is a small segment which is
Yeah, you can land
disease free.
right about there. So yeah.
So you know what I
2.2,
would do
just-
immediately? Just put a long, very long stent,
28. Yeah.
and then we can reevaluate the osteo.
28.
To be from
Because I
Austria.
think we're going to witness an abrupt closure of this vessel if you don't react quickly.
Yeah.
I will actually keep 1 millimeter or 1.5 millimeters according to my eyesight away from the ostium and then put, I don't want to get into a trifurcation or twisting at the end.
And this is where it's important to know the characteristics of the stents you're using. There's certain stents like Zions, it's a mid-marker location of where the stent is. And then other stents like Onyx, Synergy, they actually are inside the marker. So if you position the marker where you think the ostium is with those stents, then you're going to miss the ostium, which is exactly what he wants to
I'm
do.
taking a Zion Sierra.
So if you take the Zions, then you want the dot
Yeah.
inside so that if it's at the origin, then you're going to have an issue.
So Dr. Pratap, there's another
Yeah.
point here that if you put a stent right from the ostium of the ramus, you might find some difficulties later on in while doing the decay crush in negotiating your stent into the
No
circumflex.
more dye, I think.
Because that will be a crucial point. If you protrude the stent even a millimeter into the origin of the circ, then the stent into the circ would be very difficult to push in. So I think it's better that you keep the stent a little bit away from the ostium of the ramus, so that that's a much more important vessel circumflex rather than, and maybe further down, because we have some disease-free area at the origin of the ramus.
I'm glad you deployed the stent, and we can keep talking. Any other comments? Any thought?
They just kicked out of the wires.
So he said he was waiting for you to put the stent in because it was making him nervous. So I think that's right.
You know, with that hematoma and after that cutting balloon, I was worried about abrupt vessel closure, and rather have a long stent so you don't have to worry about the distal
That looks great.
normal landing zone.
Or
Then
distally,
it looks better.
you need another 12. Accordion.
You wanted to have an IVUS again now to understand how the...
So the peanut
Okay.
gallery says look at the distal end
Yeah,
of the
so
stent.
everybody's worried about the distal
Yeah, but I
portion.
think at the distal edge, because the entry site of the hematoma is already proximal and he cover enough, so even some residual hematoma distally, it's okay. You remember the distal portion was quite normal artery. It's going to be healed.
So I think that's exactly. Kiko showed a case like this yesterday, where you seal because they've sealed the origin. Even if the distal doesn't look good now, it'll probably improve. But I think you want to confirm that before you start working on the circ. and the other-
Whether it's going to improve or not, I would put a stent there.
3 millimeter, 3 millimeter.
Yes,
On the
I
bend?
think-
absolutely.
Look at the bend.
Absolutely, I would put a stent there.
I think, Alex, will you put one more stent or you just leave it?
No, I would take an IVUS down and see. Because I think there's a pretty sharp bend at that area. And so it might
Yeah,
just
there was
be-
a short bend. I was thinking that I will just leave it.
but
I will just keep the wire there. Just
you
give
can
me a
do-
3 millimeter.
Pratap, you can take another projection.
Yeah, I can show that. Which
CRA
projection you
model,
want?
or any other projection where you see whether this is just a bend or a significant stenosis or a hematoma which has progressed, and then take a decision.
just,
Sure,
I
sir,
think
I'll
the
do that.
easiest way is to do that,
Yeah, we-
but take the IVUS down and see. Because there
Looks good.
it looks okay, but it's directly on top of the guy. So just if you take the IVUS down, you'll see, and then you'll see how clear the origin was. But it looks like to me that the stent placement's actually really good.
Yeah, and you did a great job going up to the osteo. I think that this was an excellent result. But I'm still a little bit afraid of the distal edge.
See, this is actually the proximal part of the circumflex. I'm just doing a balloon dilatation. Inflate fast. 15, 18. It's a 3 millimeter balloon proximally dilated to the circumflex. No, I don't think cutting is required. Deflate.
I'm not sure if you imaged the circumflex, but I didn't see
Yeah,
too
yeah.
much disease.
Image circumflex. Image circumflex. A tight disease nearly 12 millimeters was the proximal circumflex diseased image. Can you show this image circumflex first? First one.
So there was also disease at the circumflex, at the
Yeah.
close to the-
Osteosarcoma was deceased. Can you give me the balloon to the lady? Pre-dilatation of the balloon. Actually, Kiko told that calcium is there, but that calcium can be managed just by a balloon into the lady. I think my osteal, as Ajay told, I kept 1 millimeter away from the ostium, so the balloon was easily going into the circumflex. Only point is here is an angulated LED and circumflex. So my rewiring, how tough it will be, I don't know. Initial wiring was actually having some difficulty only to the circumflex, not to the LED. Can you just keep? Go, dilate, deflate. Go,
For circ,
deflate.
uh,
Go. 15.
yeah, we don't go.
How many people will put a stent up to the LMC ostium or LMC mid part?
Wow, this left main is so big and it was so free of disease that I would try to not go all the way back to the osteum.
Yeah, you just need to have a good space for pot and for post-dilatation. So at least mid left main, because it's big and free of disease proximal.
Pratap, it's pretty funny. I mean, as you said, most people go to the Maldives for a vacation. They really made you work.
Yeah. In a complex case.
Actually, I told you yesterday, Alex, I showed this angiogram 2 days, yesterday morning. He told it's a good case, very interesting case. Luckily, we were looking for other cases, but I dilated the circ proximal as well as LED. You can see a dissection in the
Yeah, I
circumflex.
think you got
Now,
Yeah. Now you
Now
have
I
a good
will
reason to stent the circ.
no, very fast I'll do that. I will put a stent into the circumflex 3 into, what is the length of the stent?
And if you look at the distal end of the stent
No, three.
in the ramus,
Let this play
Circ-
again.
Is it better?
Let it play
Circ
again.
is 4 millimeter by IVUS. So you know how many
Yeah.
distally. You see that?
Can we see the angel again, big?
That is LED, I think.
This with this last
Three-
shot. Yeah.
3.5, 12, no.
I don't know.
Long stent.
It's also wire straightening too.
Yeah, we have to image probably.
but there's something about these arteries
That they
that,
just
that
fall
are-
apart.
Yeah.
Exactly.
Yeah, I think because that is very like link, so we may have
15 or
the
eight.
accordion phenomenon at
Yeah.
the edge. So as possible.
Any other comments on the panel on,
Yes.
on that side?
Correct.
The approach?
Circ, there is no section.
No.
15.
No comment?
No. Okay. LED, what is the length? LED, what is the length?
So Pratap, what are you doing
Yeah.
next?
Now I am actually going to do a stent into the circumflex and then crush and recross. I have to do a decay crush, you know. I have to take the wire out of the ramus. Actually, and as Alex told, anything happened to the distal ramus, I don't know.
Yeah, I mean, I think honestly though, in this case, it probably would be better to at least get a sense of what's happening in the ramus before you stent across the ramus. But I mean, obviously. And the other option
give me a-
too, Prathap, because you could also just, instead of DK crushing, where you have more carina and more metal at the carina on top of the ramus, it's actually not a bad case for a culotte either.
Now we do a mini crush maximum since it was a dissection is there. Can you just give me a balloon then? I want to do faster and come out.
Yeah, yeah.
Give me a 3.5 balloon to the lady.
I agree with Ajay. I would do culotte in this case. The left
I will
vein is
actually
big.
take the wire out of the ramus before doing anything. Lady.
I mean, with
No, that's not.
trifurcations, it typically favors culotte approach just because what happens is that the crushed metal often can sit right at that other branch, which is usually the ramus, which you're not doing much. And in this case, because you stented it, you want to preserve access to that ramus.
Absolutely.
I will actually go ahead and finish it off with the mini crush.
Yeah, I mean, I agree with that culotte approach, especially the angle of the bifurcation or even the trifurcation is very favorable for that.
I told the fellow to.
All right,
That's
so
okay,
he's gonna.
okay.
So this, he's got a balloon in the LAD, a stent in the circ, and he's lining up his mini crush so that he can get just at the origin. And some people call it a nano crush. To me, it's all a relatively short crush. And one
Go
key
to
thing
electrode.
though is after the stent is deployed, and you come down with the stent. Before you crush it, you need to make sure that there's no dissection and
small
there's good
check.
flow in the circ. Because otherwise you've crushed the stent and now you're dealing with a closed vessel. So that's just
Check.
one step that's important.
Okay. Oh, I think it is check. Okay. And I will just remove the wire of ramus. This one. This one. Just take it out. Small check again. Go, 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 go.
The distal
Dilate.
part looks better, actually.
Deflate.
So Prathap, before,
Yeah, I put a 3.5 stent because
Yeah.
even though I saw that circ is 4 millimeter, I don't want to go with a 4.
yeah,
I'm
so
just
before
taking the
crushing,
back.
before crushing, can you just do a cine to make sure that the circ is fine, and then also you'll get a look at
Correct,
the
correct.
ramus?
That is actually a very good idea, Ajay. It's okay.
Okay.
So I just wanted to dilate high
But
pressure in the
can you do a
post-
RAO caudal so we can see
RAO
what
caudal,
the ramus,
fast.
what the ramus looks like? Again, for the same reason.
And again, the distal portion
Yeah,
of the,
go ahead.
the edge of the circ, yes, there's some disease there.
Okay.
I think not much of a problem so far. So I will dilate the proximal part of the circ with a high pressure, the same balloon I am taking back. And dilate 15.
Is it-
Just wanted to open the strut very well, deflate.
Yep.
Yeah. I'm not sure if you covered the entire length of the dissection at the circ.
Circ, there was no dissection.
No, after he's talking about after the balloon, because the circ looked like basically every time one of her arteries is ballooned, it starts to dissect, and that could be a natural response to the angioplasty, but there's something going on, and so the concern is that distal part of the circ area
Small
is
check, small check,
spasm,
small check.
dissection, or something else.
Bus, don't give that much injection. Just take this wire out. Inflate, inflate. Crush, crush. No, it's okay. Crush. Deflate. Deflate, deflate. Go, inflate. What is the length of the stent to be required for LMCA?
Yeah.
Deflate. No, 20 is insufficient. Deflate.
You see the heart is beating a little bit tired. You need to give some oxygen.
Actually, the heart rate is actually low. Patient had a partial heart block. Can you give atropine?
What is the
Think so,
size of the
now-
balloon in the, Pratap, what is the size of the balloon in the LD for crushing the
LMCA.
stent?
It's actually used a 3.5 millimeter balloon. Vessels are all flowing. Only thing is there's a low heart rate.
Yeah,
Junction.
Heart rate is low.
I would think about, yeah, okay.
Sir, we will address later. We will put a stent from LMCA to LED.
Yeah, I agree. I
3.5.
think setting the
Just give me.
LED fast is a good idea.
The distal ramus is okay. It doesn't look so bad.
That was the major concern of Alex.
Now you are convincing.
Yeah, 3.5. What is the length? 38. Give me. We will actually will not put the stent up to the LM Austrian. Now it is
just
okay.
Ended in
If
the
we
mid,
picked up,
it ended about 12 millimeters back into the left main, because there is plaque down there, but
LMC is 4.6 and LED distal is 3.5. So we are going to take a 3.5 stent again, Science Sierra.
and that's an important consideration, because if you take a smaller stent than a 3.5, if he's using Zions, then it's not going to go up fully in the left main. So you really need to have a 3.5 stent. It's fortunate the LED is 3.5 at that segment, and so
A small check. Epicranial to see the distal LED. Small check. I think it is, we can actually even
forward a millimeter.
pull little back. Yeah, pull little back. Small check. Check. I think, okay, go ahead.
Is this a 38 or 48?
38.
38. Deflate. Just give me a 4.5 or 4 millimeter balloon for the LM part. Just give me fast. 4 is okay, I think. 4 millimeter balloon to the LM pot, then give me another wire to circumflex. Actually, since it is a live case, I am taking the another wire, otherwise I'll take the same wire.
And seems like she responded to the atropine. The heart rate's better.
RO caudal. Now the heartbeat is better and everything is looking so good. BP is improved. Can I get the one wire fast?
So just in terms of crush versus DK crush, the biggest advantage of the DK crush is that you can do it in a 6 French, and then the recrossing, because you've opened that strut of the crush stent, tends to be easier. But it's not necessary in all cases to do. And I think given what was going on with the dissections, etc., it was a wise choice to just stent the LED
Deflate.
and now deal with all the recrossing, kissing, etc.
Give me the wire.
Would you do sequential kissing, Ajay?
Yeah.
Instead of kissing the 3 vessels together?
Yeah, I think I would do it sequential, because I think some would say, well, do you even need to balloon the ramus? But you have a fresh stent in the ramus.
Yeah.
You want to have good flow
Give me
in
the
there.
wire.
It'd be problematic. So.
To open the struts.
Is there a question or just stretch? Okay.
I think there are some microphones, right?
Any comments from that side?
Hello, Pratap, can you listen me? Pratap?
Yeah, still I'm hearing you.
Now, the question here is that you have put in 3 stents, one in LED, one in circumflex, and the other in ramus. Conventionally, and to get an optimal result, because I am very skeptical about the ostium of the ramus. Is one area where restenosis is bound to occur. Of course, circumflex is another area. So, would you like to take a second guide and do a triple vessel simultaneous kissing?
I don't think so, it is required. We can actually, if you are taking a same balloon, actually I cross to the ramus now. So I can take another wire into the circumflex.
That's what we were saying. To do sequential circ ramus and then LED circ.
Yeah. Can you give me another wire?
No, you can. The problem is that, at this point, accessing on heparin and doing it that way, I'm not certain you're going to gain a benefit from just doing sequential.
Actually, Ajay, we can do, if you are taking a 3 balloons, and should not be 4, 3.5, 3.5 and 3. The 3 balloons taken, and I have done tracing with this same catheter. But ideally, as Dr. Gambhir told, they're better to have a ping pong technique and to have 2 catheters there and then doing, it will be easy to do, but we can manage. Let me just go back to iliocaudal to show me the. I had a difficulty of taking the initial wire into the circumflex itself. Angle is so tough.
But it might, I mean, you could even dilate into the ramus and then at least give yourself more room opening that.
Which wire are you using, Pratap?
Fielder FC.
Fielder FC.
I'll make some more bend and take it.
Yeah.
Sometimes the whisper intermediate with some bend will help.
You want to maybe take a picture here and to show us what the unique challenge is?
Circ, actually, you can see the ramus ostium is definitely having some problem.
Yeah. I think after kissing it's going to be better.
Yeah, it'll be
Just kiss there and then we'll see. And then we image to see.
Can you give me a 2.5 millimeter balloon into this?
We might need to interrogate both edges of the stent in the left circ and the stent in the LAD. So we should see what's going on at the edges of the stent distally. Yes.
What's this?
So the other thing that can help, Pratap, is if you do a post-dilatation of the left main stent, you do some pot there, it opens the struts better, and then you can have easy access to the left circ.
Yeah, he did the pot already.
He did?
I did a 4 millimeter
okay.
balloon dilatation.
Yeah, 4 or 5.
Already done.
Yeah, so it should be
Not
a little
4,
bit
5, I
easier
think
with the struts open.
I think a good crush is done.
It's having a hard time to go through the struts.
You might do a pot again with a bigger size balloon, and then you might be able to get it wire into circle.
With a 4.5.
Yeah, or he could just do that.
Oh, yeah.
You got it.
Yeah, just
That's
test.
stuck. Just come. Iliocaudal.
But this is again, if you look at the data on single kiss versus
Check.
DK, DK in a crush, it just takes longer, and there's
I'll
less.
Give me
final
2 millimeter
kissing
balloon.
with a single crush.
2.5. I will take a 2.5 millimeter balloon directly to circumflex first.
Yeah. I mean, I often just start with a 1.5 because I know it's going to be hard to get through.
No, I think that this will.
We'll see. Let's see. It's a new
there is a
balloon
pic-
or old balloon?
No, take a new.
No, new balloon.
Yeah.
For the because of the meeting.
2.5 pre-dilatation.
I inflate. I do like this. Actually, I'll call cross. Deflate, inflate, fast. 15. Deflates. 2.5 balloon. I'll take the same balloon into the ramus first. Just give me a 2.75 balloon into the ramus. This you give me. 2.75 balloon into the ramus, 3.5 into LAD, and 3.5 into circumflex. Just give me. Do a tracing and then do a 4.5 LMCA, then do 2 imaging and come out. 3 new balloons. One for inflation. The same 2.5 balloon I am taking into the ramus now. Oh.
Because it's inflated, yeah.
Yeah.
I had a problem.
Yeah,
I would use a
you-
fresh
you
one,
need
a
a new
new
balloon
one.
again.
Yeah, because too much going on there with 3 stents.
Can I get a 2.5 new balloon? $2.5 new balloon?
And by the way, if you want to do the 3 balloons, you can get another guide and then do it that way, or over 3014 wires, you can actually exchange a guide and upsize if you wanted to. But there's a lot of different ways to do
I
it.
would do sequential.
I would just do sequential.
Okay, LED flow is not. LED there is a
Distal
flow,
LED.
flow problem. LED distal is not good.
I think this plague nature is quite different.
Yeah.
Or
it's not
distal
like
and in
Yeah.
zones.
It would be nice to take a cranial shot for us to see the distal LED as well,
And just-
Pratap.
That is what I was thinking.
And just be careful with that wire, making sure that
Yeah,
you can
you
get more
don't-
distance.
Can you just come to AP cranial and see an LED distal part? I think LED distal flow is less.
Yeah, just take care of that and then you think about
Yeah,
it.
yeah, that is what.
It's just everything in her.
Yeah, it's funny that it's just some endothelial.
Everywhere there is a spasm created, അല്ലെങ്കിൽ hematoma created, and
Yeah.
Can you give the-
It's a collection of hematomas.
I mean, to be honest, it could be hematoma all the way down to near where
Yes,
the distal tip of
exactly.
the wire is.
looks
So you
like-
just got to be really careful with that wire. There you go. Nice.
Yeah, don't lose that position, please.
give me the 2.5 only. Same balloon.
Yeah,
Hematoma
focus area.
everywhere actually. When I put a wire into the ramus hematoma, here there is a hematoma probably.
You know what? And there are definitely patients like this, and the idea is you just have to be really gentle with everything. So undersizing.
I'm actually so gentle at it.
No, I'm not saying you. It's for the audience. For the audience. Yeah.
Like inject nickel by accident.
3.5.
No, 2.5 only. Just short, small balloon. Ah, okay.
This is a balloon, short balloon.
Short balloon.
Short balloon 2.5 only. I don't want to take a higher size balloon.
And
Deflate.
Pratap, I would personally take the IVUS down and see how far down.
I will do that. Now I will do an IVUS now.
Yeah, no picture,
Deflate.
just IVUS.
Yeah, probably another
I was-
stent today.
This one. IVUS. Yes, you know that today. Today. Can you just give me IVUS fast?
How is it the feeling and the hemodynamics, heart rate, pressure?
Very good. Actually, BP is
Stable.
158 by 88. Heart rate is sinus rhythm. Heart rate is 88 or 90? 76.
No, so
No symptoms.
now one of the nice things about the new IVUS systems is that you can change the pullback speed. So you can certainly make it faster, and in a case where you're worried, you can increase it to
Start IVUS.
1, you can make it 2,
IVUS.
just to get
Image.
the scan.
Okay, so this is a very distal beyond the stent, and you see the nice normal artery.
So that's very
and myocardial
reassuring.
bridge,
That's
it's good. It's a little bit spastic. Okay, we see the hematoma again.
Yeah.
You have to follow. This is hematoma in the normal segment. Chirulume was pushed. Still hematoma at the 9 o'clock.
And hope everybody in the audience can see that,
Ah,
because these are some
Yeah.
of the best.
So this is
Huge
very
ones.
classic type of the hematoma. You see the IVUS catheter in the chirulumen, and 6 o'clock, 9 o'clock, 12 o'clock, hyperintensity, helmet shape. That's like back and forth. We see the entry site is 2 o'clock. That's a big dissection which was not covered, and that's stent.
It's at the edge
And
of it.
actually, stent was good to expand it. I think we need a stent
Yeah.
without any dye.
So there is a empty dissection with hematoma, Kiko.
Yes.
So we have to cover it.
Yeah.
The entry point is right at the distal edge of the stent.
Yes.
Yeah. And if you look, by the way, at the longitudinal view on the bottom right of the screen, you can see really nicely the depiction of the hematoma.
Yeah, by the way, let's look into the proximal edit. It's also somewhere here is underexpanded. We should go a little bit more. That's one thing.
Gary, maybe we're a little bit oversized. That's why we had the.
Yeah, in terms of the distal segment.
Plus the distal edge
And this
ended
portion
in a
was-
normal segment of vessel.
Yeah, actually, that was close to the myocardial bridge. So that's a trifurcation. One is from the limus, one is from the circ, and this is a distal left domain. And you see the multiple layer in the 6 o'clock, that's a crush stent, and that's a proximal segment of the left domain. And the left domain stent was well opposed, and he covered almost up to the end of the left domain, which is quite normal. So I think the distal left domain have to expand more, which seems to be underexpanded as well.
And by IVUS, you can measure the edge of the stent until that normal zone, so you can select precisely
Can you show the IVUS measurement?
the stent length.
So go to the distal edge of the stent.
Measure.
Actually, can you, Shanice, can you show that distal edge?
Yeah.
So I would take a 2.5 stent,
Yeah,
and
max to 2.75, but
So that's, okay, so this is a
Go-
stent.
go
Go a little bit distally.
distal.
Stop. A little bit more. Stop.
Yeah.
That's a distal edge.
Yeah,
So,
15 millimeter stent will do it,
Yeah,
right?
measure from here to,
Let's see.
and again on the
Thank you.
longitudinal view on the bottom right, you can just see very nicely exactly how long.
18.7.
18.
18 millimeters. With overlap, with overlap?
23. I would take a 2.5.
Yeah, take a
23.
little bit longer.
23, 2.75, I think. What do you think?
2.5.
2.5.
There's no difference between a
Yeah.
2.5 and a
2.5.
2.75.
And if you need to post dilate, you do it. But I would
2.5.
275
smaller
can
one.
make both dissection.
Actually, this
But
is
here there
normal
is no
segment.
flag.
I don't think we
Normal.
need a high pressure. It's really pushing
Yeah.
the hematoma only.
And can you go back to the angiogram? Because I'm
You want to
assuming-
see one more angio shot?
No
No.
pictures, no pictures.
You had a picture before.
No, I thought you had sinnate or stored the fluoro at the distal landing segment. But it doesn't
Can you
matter.
show the previous angio shot?
And
Yeah. You see?
Yeah.
Biangio looks longer. I don't know how far you went with the Avus.
It's
catheter.
okay, at least you know
Yeah,
the
you close.
measurement.
Yeah, that's
So
right.
if you line up the stent at the stent, then it should be okay.
Compared to this angio, hematoma much longer because we inject more and more. And
Yeah.
because of the entry site was open, by distal to the stent edge, he make worse.
So Akiko's point is this is
If you
dynamic.
look at the
In
angio, it is
real
longer.
time, by
Can-
angiogram, it
it
looks
can
worse than
extend.
it did with the IVUS.
Yeah.
So just line it perfectly, don't inject, and then just deploy.
1 millimeter overlap, and then you're gonna.
Clearance stent, can you give me?
If you have stent
Stent
boost.
boost or something.
Little more distally.
Sila, med taduan. Med. Med rangalwa. Ni mengwa.
ഒന്ന് പെട്ടെന്ന് ചെയ്തേ. Are you ready? It's okay, it's okay.
Yeah.
No, I'm not injecting. Nothing can be seen. So can you see that
Yeah, it's
It looks
overlap.
pretty close.
overlap? Go.
Yes.
Nominal.
And this is a 23, right? Yeah.
23.
Just 12.
Deflate.
No-
We actually went only nominal pressure.
Actually,
Go.
2.5 is
10, 12, 13, 14.
Yeah.
Deflate.
But overlap.
And so I would just take the IVUS catheter down again and see
IVUS catheter, can you give me?
before injecting. I mean, honestly, this is a really, really great demonstration because this is not the type of case that you typically see in a live case where you're chasing hematoma and having to manage it in real time. But this way of not injecting, just IVUSing, being careful but not too careful, not too slow, it's a real It's a skill that it takes time to master.
And the stent selection for this LAD is not a simple decision because you want to go all the way to a big
you
left
talk
main,
with him?
right? So there is a
Ali.
trade-off. Probably, the choice of a
Relax.
bigger stent caused this dissection, but it was good for the left main. So it's a sometimes hard decisions.
GP can you check?
And this is also a stent probably in the bridge as well, right, Akiko?
Yeah,
Angga
we
tem
cover the bridge.
Angga tem ada.
Yeah. Go a little
Can you just go
bit
to the IVUS?
IVUS live.
IVUS, please.
Okay, so this is supernova segment.
And there's flow.
And
You can
this
see
start
that
to
there's
the-
good image, there's flow, so you're good.
Yeah, this start to the stent.
Transition is beautiful.
And
Oh no, not yet.
that's the myocardial bridge. This is bridge and spastic bridge. That's a septal. And this is still supernova. Okay, ended
perfect,
the
perfect.
stent. Unfortunately, this stent was implanted in the bridge. You see the bridge is 9 o'clock. You see that now it's 12 o'clock. That's a bridge. Typically, inside of the bridge,
Okay,
no
okay.
disease at all. So, but anyway, it's okay. Everything was covered. We
Little
don't see
water you can
the
give.
overlap yet, but I think stent expansion is okay. I don't think we should expand too much more.
No.
I still would like to see some residual lesion at the distal, Kiko, but I
What?
think it should be fine.
There is no disease at this study. It's just like
Do you think
spastic.
it was a band or the bridge? Because there was
The-
some lumen reduction there.
No, that was myocardial bridge.
Okay.
Yeah.
But Akiko told me that the proximal LED to be dilated a little more and LMC also to be dilated, right?
Okay, let's talk together. So now we see the overlap segment. This is the original 48 millimeter stent which you implanted. By the way,
That's
this is
38.
also okay. Sorry, 38. Still, there is a bridge that was covered. It's okay. So I think stent expansion by now is so far so good, and we're just looking at the original region segment somewhere here. This is somewhere I do think the underexpanded compared to the size of the vessel. We have to open up more. Here too, this is, you see the calcium outside, that has to be expanded more. And this is a trifurcation, circumflex and remus. This is a distal left main. You see that like 3 layers stent, which is crush, and that has to be opposed more. And then this is a proximal left main. So I do think the proximal LAD and distal left main has to be expanded more.
So this is, I think, super helpful, and I'm glad that the hematoma was covered. Prathap, we're just under 2 minutes, so we're going to have to probably leave you, but you're basically going to post-dilate the LAD.
I will actually show one angio shot in the distal to the epicranial and ariocaudal, and then I will do the other work and you can leave.
That's great. And your plan for the bifurcations is just sequential
Will be
kissing?
twisting, 3.5, 3.5, 2.75 to the ramus.
Yeah. All right, so can we go back to the angiogram?
Yeah. Can you just show the angiogram?
Okay.
You can see the distal to the stent some problem, but actually IVUS wise nothing is there.
No, that was myocardial bridge and also spastic.
Okay.
That's the explanation. So no edge dissection anymore.
All right.
Ramus, can you make it a bigger one?
4.5.
Ramus virus little. No, just magnify.
This is great.
Yeah.
And even that mid-circ thing looks
Scary.
a little better, but probably with nitro it'll get better. Yeah. It's a very interesting case, I have to say, from start to finish. And
I would image the circ.
Yeah, you have
as
to
well.
image that circ and see.
But with a final touch of kissing at left main and LAD and circ, I think it's going to be fine. But,
Alex, will you do anything to the distal part of the stent of the circumflex?
I would do IVUS around there.
Yeah,
to
nitro, IVUS, and
Yeah.
C. Because remember, with everything you do with her, it's going to be problematic. So. But again, as I said, Prathap, not a vacation, but I think you're helping her, which is great. And thanks for the demonstration, and to the whole team over there, really, really great job.
Great case.
Thank you very much.